Goodin with clinical assessment, diagnosis, and treatment approaches. Psychological assessment is the procedure by which clinicians, using psychological tests, observation, and interviews, develop a summary of the client's symptoms and problems. A clinical diagnosis is the process through which a clinician arrives at a general summary classification of the patient's symptoms by following a clearly defined system, such as the DSM-5 or the ICD-10, which stands for International Classification of Diseases. That's published by the World Health Organization. You need to know what the presenting problem is. That's normally a client will come into your office and you say, "What brings you here today?" And whatever they say. It may not be exactly what they say, but you eventually figure it out. It's the major symptoms and behavior the client is experiencing. Diagnosis may be necessary for insurance reimbursement. You need to remember that. And clinician notes should contain much more than the diagnosis. It should have a social and behavioral history. You're going to note personality factors as well. Assessment should include a description of any relevant long-term personality characteristics, social context, so whatever environmental demands are on the person, the diverse and often conflicting bits of information about the individual's personality traits, behavior patterns, environmental demands, and so on, must be integrated into a consistent and meaningful picture. This is called the dynamic formulation. Dynamic formulation, because it only describes the current situation. It should allow the clinician to develop hypotheses about the client's future behavior as well. Decisions of treatment made in collaboration with the client will be made in collaboration with the client when possible. And culture also matters. This is a big deal these days. Now that our society is starting to care, psychologists who use tests in a culturally competent manner must keep in mind a range of issues and factors involved with culturally and linguistically diverse students. There's often a medical evaluation, assessment of potential organic factors. If it's not purely psychological, we want to know that. Sometimes needed to rule out the possibility that physical abnormalities may be causing or contributing to the problem. There's often a general physical exam. Medical history and major symptoms of the body are checked. There's often a neurological examination, which may be needed when there are, for example, unusual memory deficits or motor impairments. An EEG is an electroencephalogram. It assesses brainwave patterns in awake and sleeping states. It gives a graphical record of the brain's electrical activity. An EEG can show a dysrhythmia, an irregular pattern in the brain's electrical activity. And then we have different types of anatomical brain scans. The CAT scan, which stands for computerized axial tomography, is radiological technology. It uses x-rays to reveal images of parts of the brain that might be diseased. It points out anomalies in brain structure. The MRI stands for magnetic resonance imaging. It has replaced CAT scans in some cases. Gives sharper images of the brain, which especially the soft tissue, and is less complicated and doesn't use ionizing radiation. The PET scan stands for positron emission tomography. It allows the study of organ functioning. It tracks natural compounds as they are metabolized by the brain or other organs. It currently still produces low resolution pictures, or low-fi pictures. The fMRI, which is a functional MRI, is used to study psychopathology. It measures changes in local oxygenation, in effect the blood flow of specific areas of brain tissue that in turn depend on neuronal activity in those regions. Ongoing psychological activity, sensations, images, and thoughts can be mapped, and it shows what parts of the brain brain are involved. A neuropsychological examination is the use of various testing devices to measure a person's cognitive, perceptual, and motor performance as clues to the extent and location of brain damage. A psychologist or therapist will administer a test battery, means a group of tests, standardized tasks, and perceptual motor tasks. Only organic tissues can be tested with these, and all neurological exams or anatomical brain scans. Psychosocial assessment is for non-organic mental issues. It provides information about the personality makeup and present level of functioning. It gives information about stressors and resources in the client's life situation. Clinicians are basically puzzle solvers, absorbing the information, making hypotheses. The assessment interview is usually face-to-face interaction in which the clinician gets information about various aspects of the client's situation, behavior, and personality. It may vary from open and simple or structured and detailed, and based on which type it is, it may gain or lose reliability. A structured interview is when a clinician uses predetermined sets of questions throughout the interview. These sometimes have way too much detail and don't feel personal. It's best to carefully structure an interview in terms of goals, comprehensive symptom review, other content to be explored, and the type of relationship the interviewer attempts to establish with the person. An unstructured interview is more subjective. It's influenced by theoretical views of the clinician, and it's different for each client, so you might miss information, and you can't compare one person's interview to another. However, giving that up, it is more sensitive to each client individually. Clinical observation of behavior is direct observation of the client's characteristic behavior in an attempt to learn more about the psychological functioning by looking at appearance and behavior, personal hygiene, emotional responses, any psychological manifestations like anxiety. It's best studied, observed in a natural environment, but more often is done in a clinic or a hospital. So we might lose some ecological validity in that way. Self-monitoring is when clients are asked to self-assess and self-report. This is really common. Rating scales organize information enabling the presence or absence, basically the degree of a characteristic. So an example would be a brief psychiatric rating scale. Other scales are more targeted to specific illnesses. Psychological tests are an indirect means of assessing psychological characteristics. These may include intelligence tests like the Wechsler, Stanford-Binet, things like that. The test vocabulary, which is verbal ability, or a digit span, which is more of a performance ability test. It's useful in case of brain damage, cognitive functioning, because it measures intellectual resources. A projective personality test is a measure of personal characteristics using various ambiguous images. Interpretations give information. These are done by highly trained clinicians, and the most famous that you may have heard of is the Rorschach inkblot test. These are more psychoanalytic than behavioral and sometimes have questionable validity. The Rorschach tends to be well respected. Other types are the thematic apperception test, or the TAT. It uses simple pictures to elicit the client's stories about them. The sentence completion test is related to free association methods. It gives a sentence stem, and then a person will finish that sentence. Objective personality tests are structured and more reliable and valid. The MMPI is quite famous. It's the Minnesota Multiphasic Personality Inventory. It's the most widely used test for personality, forensic, and psychopathology. The integration of assessment data is important. There's a significance of assessment data in its interpretation, usually by a clinician. By putting together all the information they have gathered, they can see whether the findings complement each other and form a definitive clinical picture of whether gaps or discrepancies exist that necessitate further investigation. It also leads to a tentative, which means temporary, diagnostic classification of a patient. Factors to keep in mind are the potential cultural bias of the instrument or the clinician, him or herself. The theoretical orientation of the clinician is often important to note. It's also under emphasis of the external situation. What's the environment that we're getting our information in? Insufficient validation is important to note, and inaccurate data or premature evaluation is problematic. So classifying abnormal behavior, previously done with earlier versions of the DSM, Diagnostic and Statistical Manual. Now it's done with the DSM-5. This is a classification system that provides confidence of clear communication and makes generalizations about what is being observed. And reliability and validity vary by instrument in terms of psychometrics. There is formal diagnostic classification of mental disorders in the ICD and the DSM. Criteria that defines categories consists of symptoms and signs, where symptoms are the patient's subjective description, often complaints he or she presents about what they say is wrong with them, and signs are objective observations, direct or indirect, of the client. So the client may not give eye contact, for instance. Then we have the 5 axes of the DSM. Now I want you to note in the new DSM-5, it no longer uses the axes, but I do want to touch on them because some clinicians are still using earlier versions, such as the DSM-4 TR. Axis 1 had to do with clinical syndromes like schizophrenia, anxiety, and depression. Axis 2 had to do with personality disorders, which were problematic ways of relating to the world. Histrionic, paranoid, antisocial. Axis 3 had to do with general medical conditions like chronic pain that could play a role or result in depression. Axis 4, psychosocial and environmental problems and environmental stressors. Axis 5 was the GAF, or the Global Assessment of Functioning. On a scale from 1 to 100, the clinician would rate the client's overall ability to function. They would also note things like, and they still do this, are the issues acute or short-term versus chronic, which is long-term? Is the problem mild, moderate, or severe? Is it episodic or recurrent? And there are always labeling issues. So with treatment, psychotherapy insists people with psychological problems can change. They can learn more adaptive ways of perceiving, evaluating, and behaving. Behavioral therapy is direct and active treatment that recognizes the importance of behavior, acknowledges the role of learning, and includes thorough assessment of evaluation. It focuses on the presenting problem. It has a major assumption that abnormal behavior is acquired in the same way as normal behavior, by learning. And the goal, then, is to unlearn. Exposure therapy is guided exposure to anxiety-provoking stimuli, such as systematic desensitization, which is gradual, or flooding, which is all at once. can be in vivo exposure or imaginal. In other words, in real life or imagined. Aversion therapy punishes undesirable behavior. Example would be like antabuse, which is taken and induces nausea and vomiting when someone drinks alcohol. Modeling is when a client imitates a parent or therapist performing healthy behavior. The therapist thinks out loud often during therapy, so that the client can learn ways of thinking. There's a systematic use of reinforcement often. It's called contingency management, removing reinforcements that support problematic behavior. If you were to quit smoking, you would need to quit going to places where there's a lot of smoking. Response shaping positive reinforcement is used to establish gradual approximations of a healthy response. Token economies are often used. Think of school or your kid's school when they received a gold star, and maybe they received 5 gold stars and they'd get a gift or a little toy. It uses behavioral activation to treat depression and help a patient find ways to become more active and engaged with life. So behavioral activation could be online dating, could be ways to get people just started in the right direction. So I want you to get a shave, get a haircut today. That may be a start towards feeling better about oneself. So in cognitive and cognitive behavioral therapy, there are 2 main themes. Cognitive processes influence emotion, motivation, and behavior, and techniques used in a pragmatic or hypothesis testing manner. REBT, or Rational Emotive Behavior Therapy, was developed by Albert Ellis. It changes maladaptive thought processes on which maladaptive emotional responses and behavior depend. Many of us learned unrealistic beliefs, perfectionist values, and the goal is to restructure our belief system and self-evaluation. Irrational shoulds, oughts, and musts should be gotten rid of. We need to dispute false beliefs through rational confrontation. Beck's cognitive therapies assumes problems result from biased processing of external events or internal stimuli and distort the way a person makes sense of experiences, leading to cognitive errors. It's based on faulty schemas. The client is asked to test dysfunctional hypotheses based on faulty beliefs, analyze results with the therapist. Automatic thoughts are the dysfunctional schemas that make a client vulnerable. We all have, a lot of us have automatic thoughts that sort of pester us. They harass us. It's think about a recent breakup, and then you can't get rid of, every time you get on your computer, you might have an automatic negative thought, or it could just be a reminder, or it could be sort of a feeling about oneself. And they play a role in panic disorder, general anxiety disorder, bulimia. Then there are the humanistic experiential therapies, which assume we have freedom and responsibility to control our own behavior. We can reflect on our problems, make choices, and take positive action. And there's client-centered therapy, which was developed by Carl Rogers, focuses on natural power of the organism, which is the patient, to heal him or herself. We want to remove restraints that a person should feel or should not feel a specific way, like hostility. You shouldn't feel hostility. We want to remove the restraints on feeling that and let them feel it. The goal is to help the client be able to accept and be themselves. Unconditional acceptance is really important in this type of therapy, to be understood and valued as people. There's often empathic reflecting, exploring real feelings and thoughts. And there's the idea that a person is incongruent. They're feeling hostile, but they think they shouldn't. And we want them to become congruent so that they can say to themselves, you know what, I am angry. All right, and they can work on it from there. Gestalt therapy. The word gestalt means whole. It emphasizes unity of mind and body, emphasizing the need to integrate thought, feeling, and action. The goal is self-awareness and self-acceptance. Body consciousness might say, what does it feel like in your gut? There's process experiential therapy, which combines client-centered and Gestalt therapies, emphasizing the experiencing of emotions during therapy. The client reflects on emotions and creates meaning from them. Psychodynamic therapies involve a broad treatment approach, focusing on individual personality dynamics from a psychoanalytic perspective. It's the oldest form of therapy, based on Freud's original ideas. There are two types: classical psychoanalysis and psychoanalytically oriented psychotherapy. Classical would involve an intensive, like 3 times a week, long-term sessions to uncover repressed memories, thoughts, fears, and conflicts stemming from problems in early psychosexual development, and to come to terms in reality of adult life. Example would be rigorous self-control derived from difficulties in toilet training. Psychoanalytically oriented psychotherapy is based on psychoanalytic concepts, but may differ in principles and procedures. So it may be less frequent. A person may not be laying on a couch, they may be sitting up in a chair and have an active conversational style. Freudian classical psychoanalysis has 4 basic techniques. Free association. The patient must say what comes to mind, regardless of how personal, painful, or perceived relevance. They often are on a couch, and one idea leads to another. The therapist sits normally behind the couch and ties together the statements into a meaningful explanation of maladaptive behavior and repressed or unconscious events and fantasies that drive it. There's often the analysis of dreams to uncover unconscious material. Repressive defenses are lowered. Forbidden desires and feelings may find an outlet in dreams, sometimes symbolically. The word manifest content is what is the straightforward content, whereas latent content is disguised. And then we might analyze resistance. Resistance is the unwillingness or inability to talk about certain thoughts, motives, or experiences, such as a person switching topics or forgetting an appointment altogether. And we might analyze transference. The relationship of the client and therapist may become complex and emotionally involved. The client may transfer attitudes and feelings towards other people, like one's father, onto the therapist. The countertransference is when the therapist transfers attitudes and feelings that he or she has onto the client, and that can be a little dangerous. The therapist must be self-aware of what they're doing. Object relations perspective. The objects, again, are other people, and there's a focus on interpersonal relationship issues. Couple and family therapy is used with distressed relationships. Couple therapy is normally done too late. The couples are seen together and work to improve communication skills, work on problem-solving styles, and both partners must change. But normally, especially in marriages, this is often done about the time people are about to get a divorce. It's sort of a last effort. Traditional behavioral couple therapy, or TBCT, views marital satisfaction and distress in terms of reinforcement. The goal is to increase caring behaviors and teach partners to resolve their conflicts in more constructive ways. And this is not appropriate for all couples. IBCT is a little different. Integrative behavioral couple therapy focuses on acceptance of reality and limitations, less emphasis on change. Relationship themes and the needs of the couple are emphasized. And I'll note here that probably the best and most well-researched book that deals with couples therapy or marital therapy is The 5 Principles of Making Marriage Work, if you care to look into that. Dr. John Gottman, I believe, Gottman. Family therapy is done when many individuals relapse. Family therapy is done, but there's a big problem with many individuals relapsing when they return home. Structural family therapy is if the family context can be changed. Individuals will have altered experiences and behave differently with a new family structure. It's more supportive and less pathogenically toward each other. Typical family interaction patterns are often rigid or have flexible boundaries, and the power structure may need to change, and the idea of scapegoating may need to be stopped. Structural family therapy is often used with anorexia nervosa, which has a lot of ties to the family dynamic. Eclecticism and integration is really just the idea that we're using different types of therapy all at once, multimodal therapy. We borrow and combine concepts and techniques, and most therapists do this, at least to some degree. We measure success by the therapist's impression of changes, client reports of change, reports from the client's family and friends, comparison of pre-treatment and post-treatment scores on instruments, and measures of change in selected overt behaviors. There's an emphasis on using quantitative, which means measurable, methods of measuring change. And it's also common to mention that change may be non-linear. In other words, there may be sudden gains. Like, man, I was in therapy for a year, and then all of a sudden, 1 week, we just had this session, and it's like an eye-opening experience. Biological approaches to treatment often include psychopharmacology, determining which drugs work to alleviate which mental disorders and why they do it, why they work or don't. Antipsychotic drugs are called neuroleptics, and these are used to treat psychotic disorders such as schizophrenia and psychotic mood disorders. It reduces the intensity of delusions and hallucinations by blocking dopamine receptors. It may be used with Alzheimer's. It may cause tardive dyskinesia, which is a movement abnormality, a delayed result of taking antipsychotic medications. Of course, there are other side effects as well. Antidepressant drugs, probably the most common are selective serotonin reuptake inhibitors, or SSRIs. The most famous one is probably Prozac or fluoxetine. It increases the availability of serotonin and or norepinephrine, preventing its reuptake. It's considered safer. This new class is the SNRI, serotonin and norepinephrine reuptake inhibitors, and that would include things like Effexor and Cymbalta. It's made to block the reuptake of both. One thing you want to note here is that all these antidepressants take about 4 weeks before they reach effective levels in the bloodstream, and for you to start seeing a significant change. You may be asking yourself, do they cause suicide? Let me try to explain that in a simple way. Normally, a person who is greatly depressed is at zero level energy. Okay, zero level energy. Now, they may think to themselves, I wish I could kill myself. But they do not have any energy or motivation or volition. Nothing inside them besides their mind says, I will do this. And they lay in bed. They do nothing. They do not have the energy to plan out a suicide attempt. Now, one reason why antidepressants are tied to suicide is because they get that person from zero level energy and motivation and volition up to 1 to 2 to 3 to 4 to 5 even, maybe on a scale from 1 to 100, and just that little push, they're still in the very dangerous zone of suicidal thoughts and ideations, and they start to get just a little bit better, not happy enough to feel safe, not energetic enough to be totally carefree, but still in the dangerous zone of suicide, but improving just enough to where they have some of the energy to actually take action towards their suicidal urges. And this is one reason why we might see antidepressants tied to suicide. We might also wonder why people stop taking drugs. Well, the side effects are horrible, first of all. It may take 4 weeks for it to start working, and then you've lived with side effects for those 4 weeks, and it really doesn't work as well as you hoped, and the doctor wants to try you on another drug. Well, it gets really old really quickly, and often our therapists or psychologists, psychiatrists have not been through depression themselves and do not understand how hard it is just to make yourself go to the doctor and talk about therapy, or even just to take a pill every day. So I wanted to note those things. Moving on to the third bullet here, MAOIs, monoamine oxidase inhibitors. They were developed for tuberculosis and resulted in elevated mood. They inhibit the activity of monoamine oxidase, an enzyme in the synaptic cleft that breaks down neurotransmitters. It has strict nutritional limitations. You can't eat salami, certain types of cheeses. And another type of antidepressant is the tricyclic. This is the older. It was known for having more side effects, but may still be appropriate for some people. Of course, we also have anti-anxiety drugs. You may have heard of benzos or benzodiazepines, is the full name. Most important and widely used of anti-anxiety drugs, of course, there are different types. There's the risk of psychological and physiological dependence. If a person has withdrawal, there's a risk of seizure. But they work by enhancing the activity of GABA receptors. GABA is an inhibitory neurotransmitter of anxiety in stressful situations. Lithium and other mood stabilizing drugs treat bipolar disorder, but require blood monitoring. ECT is electroconvulsive therapy. It's the use of an electric current through a patient's head. It's used as a last resort. It may be used with pregnant women or elderly who can't take certain medicines. It can be bilateral or unilateral and may cause short-term amnesia. It basically reboots the brain by inducing a very, very tiny seizure. Um, think of a person having a chemical imbalance, and with this reboot of the brain, the idea is to reset the brain to a balanced state. Neurosurgery is not done much anymore. It is rare today. Think of a prefrontal lobotomy. It's an absolute last resort for people perhaps with debilitating obsessive compulsive disorder, treatment resistant, severe self mutilation, intractable anorexia nervosa. The problem, it creates lesions. And there's new deep brain stimulation that does not cause lesions. Um, Actually include drills holes into the brain with an electric current to implanted electrodes. All right, thank you very much. I'll see you next time.